older generation, we would come back in 6 months, roughly 20-25% of the people would come back for us to go back again and try to open it because scar tissue would close these stents. So that remains to be kind of the state of the art of treatment of heart attacks. But of course, in patients that are not suitable for balloon angioplasty or stenting, if they have this so-called left main or the main artery disease, or if they have too many blockages in too many places that we don't think they're ideal for stenting, you end up just kind of ballooning the artery that is 100% shut off and getting the blood through it, and then quickly shunting them to a cardiac surgical program. But this probably happens right now, it seems to happen maybe 5% of the time or less. In our experience with the sophistication of the care, it seems like somewhere about 5% or less we end up rushing the patient when they come with a heart attack. Majority of the times we can stabilize them with interventional methods, gain some time, so we don't have to really immediately rush them to a heart surgery. But still, heart surgery has a key role when there are multiple blockages and so on. And since we are coming to the last 10 minutes or so of the discussion, I also wanted to touch base about and also make the audience aware that at Opelousas General we have 4 fully trained interventional cardiologists now. This is the first time in the history of this. That is in our group, and there is one other cardiologist practicing who is a fully trained interventional cardiologist. So really there are 5 physicians who are thoroughly trained in interventional space that cater to patients presenting with these problems. The key is in patients recognizing them, getting in a timely fashion. Everything else will be taken care of once they do get there. And second, I want to just kind of take a step back and talk about the radial approach, which has kind of made a comeback and seems like came a much stronger comeback. So I want to ask Dr. Venkat about the so-called radial access in doing angiograms, and what is the benefit of it, and what is the radial access in the first place, and why do it?
Right. Traditionally, most of the hospitals and most of the times we were practicing doing cardiac catheterizations through the artery in your leg, which is the femoral artery. Even at this point of time, 90% of the institutions in the US perform it through the femoral artery. Now, radial artery is a procedure where we do it through an artery in your arm. This is the radial artery, and we get to the heart through specialized sheaths and catheters. Now, this procedure has been there for like 20-25 years, but it kind of fell out of fashion because of, we didn't have the specific catheters and sheaths at that point of time, and we had difficulty using them. But now, thanks to the technological advances, we have excellent sheaths, newer catheters, which make it much more easier. Now, why do it? Now, it is important. These are very important for patients who have problems, like, let's say, who are obese, who have back pains, who cannot lay in bed for too long, or patients who have COPD, or patients who have other conditions which did not let them to lie in the bed for a longer time. This procedure is much better because they can have the procedure done and sit up right after the procedure is done. So the first advantage is early ambulation. In the medical community, the biggest advantage that people have seen is the risk of bleeding has significantly gone down. The risk of bleeding with procedures through the femoral artery was about 5%, and particularly when we do interventional procedures, we give them a lot of blood thinners, so that puts them at a higher risk for bleeding, as opposed to radial artery procedure where the risk is virtually closer to 0. It's not 0, but it's closer to 0. So that's a big advantage for people who perform the procedure, and of course for the patient because the risk of bleeding is significantly lower.
Absolutely, well said. In radial artery, as he was pointing out, basically you're used to using your wrist artery right about here on the mid towards the thumb side of it, and get in there and potentially do everything primarily as it pertains to the heart. Maybe if you're doing the neck arteries to some extent, and of course if you do interventions in the legs and others doing through the radial artery, it may not be accessible. The catheters are not long enough, or the technology is not quite there to perform a variety of interventions in the leg arteries and these kinds of things. But certainly as it comes to the heart, the biggest thing, as he pointed out, is that if you did the femoral artery or the artery in your groin area, they were a lot deeper, more complex structures, and the tissues surrounding them are a lot more deeper. Depending on the patient's body weight, we could not compress them adequately. in spite of having multiple iterations of these so-called closure devices, plugs, sutures, and all the above, have minimized the risk of bleeding and discomfort to the patient. But in spite of the best efforts of all these things, there is still a significant risk, especially when you end up giving blood thinners and you end up doing punctures. There is a risk of this so-called retroperitoneal hemorrhages, which can totally be a nightmare to all of us, and most importantly to the patients. It could potentially be life-threatening. A significant bleed can be potentially life-threatening, and when you admit them, transfuse them, and the cost to the hospital and the patient and the medical community goes up substantially. The goal of doing radial intervention, at least in a select subgroup of patients, that we do elective angiograms and potentially in future doing emergency procedures as well, is to minimize that risk to the patient, reduce the amount of time. It used to be 6 hours they would stay in bed, somewhere up to 6 hours. Even with closure devices, you're forcing them up to 4 hours. Now that is virtually gone down to, as soon as they get up from their sedation from the procedure, they can get up and probably sit up in their bed and have a little water, have a light something propped up in the bed, as opposed to laying flat in the bed, being extraordinarily uncomfortable. In people who have a variety of other problems, as he pointed out, it may not be that easy. So it definitely has made a strong comeback. And many years ago when we trained, there was some romance with this technique. But then the catheters and the whole technique hasn't evolved to the point to do it in every patient. But now it seems to have made a strong comeback across the world, primarily driven by the technology, and secondarily, once you start offering it to patients, gradually patients will also embrace this technology more. Who doesn't want to get up and walk around a couple of hours after a highly invasive procedure putting stents in their heart arteries? So we are pleased to just kind of again let the audience know that we are one among the few institutions, probably one among the only institution in this area at this stage offering this procedure to the patients to simplify their lives and simplify our lives as well. And we are happy to, Dr. Venkat has extensive training, and I've trained some years ago, and certainly I'm more than glad to embrace it. And Dr. Hammett and Dr. Minyard, I'm sure, will follow very, very soon here to definitely get in that pathway. And so tonight we just end up spending a lot of time talking about heart attacks, talking about the timeliness of heart attacks, talking about getting here and having the technologies. But of course, we also want the audience that are farther out from us. Say they are, of course, if you're having a heart attack, the ambulance drivers typically take you to the nearest emergency room. Those are their instructions. God willing, if you're close enough to an ambulance room where, the emergency room, where physicians or the whole technique is available, like in Opelousas General, where you do primary angioplasty, that is fine. But on the other hand, if you do get out to much more remote institutions, there is a significant impact even in getting there in a timely manner, in that the clot busting medicines can be administered, and they are right close to the interventional approaches or angioplasty in their success rate and prevention of heart muscle damage. So patients should not get discouraged. Patients should not make any efforts to go to big fancy hospitals elsewhere, and they should get their ambulances, call 911, get your ambulance, get to the nearest hospital, get the right treatment, let the physicians decide what is the right form of treatment. And if you don't stabilize after the clot busting medicines, they can put you on a helicopter, put you in an ambulance again with a sophisticated paramedical team, get you to a nearby hospital which is equipped to do it, be it in Opelousas and be it in Lafayette or any other regions like that. So this has become standard of care. So we really, the goal is to encourage patients. The main purpose of doing this show is to encourage patients to be highly aware of this symptom complex. When you believe that you're having a heart attack, you have the right risk factors, including if you're a smoker, if you're a diabetic, you have high blood pressure, you're 50 years of age or higher typically, or if you have a strong family history of heart attacks, you should have a very, very, very low threshold of calling a paramedic. Stop what you're doing, call the paramedics. If you're a person who has had prior history of angioplasty or stenting, or had bypass surgery, if you start experiencing any of these symptoms, if they're not resolved by taking nitroglycerin, call the paramedics. Don't waste any time. Don't just sit there and try to figure it out, because time is muscle. That is the key message we tried to convey tonight. It looks like we have one more caller here to finish the show. Mike from Lewisburg. Mike, you're live. Go ahead.
Yes, how y'all doing tonight?
You're doing well, and you?
I was calling I wanted to comment on your outlying areas as far as getting you to the hospital. 3 years ago, I had a heart attack, and it was one of my, I think out of 5 I've had. Dr. Hammond and his crew was very sufficient. The ambulance got me there within 20 minutes. When I arrived at the hospital, he had his full team waiting for me. And I just wanted to let y'all know that, he saved my life. I had a blood clot that time, and before it was all plaque built up. But this time it was a blood clot, and according to him, it was a stent that saved my life. It held the blood clot from getting to my brain.
Well,
but I just wanted to comment and say great job he did, and really grateful. And since then, I've had bypasses done, so now he's just treating for that.
fantastic, Clay.
Appreciate the feedback.
Clay, that just reiterates the whole discussion. One, kind of the endorsement from a patient. You had the fortune of being treated by you in a timely manner when he had a clot or a heart attack that was, and then, like we just iterated again, once you do that and you get over the hump in that acute period, you then have time to, if the patient has multiple other blockages, as in this case, this patient had mentioned that he had eventually gone on and had bypass surgery. So that's really pretty much how it works. And fortunately, a lot of times, and if there are 2 or 3 blockages in focal locations, the drug-eluting stent technology has enabled us to do even 2, 3, 4 stents sometimes, and potentially have equally good results as compared to bypass surgery. So this is the whole beauty of doing all these things here, and offering technologies and having the full team available, so to speak, just to enable this, because this is definitely a team effort. It takes tremendous amount of infrastructure, tremendous amount of planning, tremendous amount of support and resources for us to enable this. We are fortunate that in this country that we have all those resources. So really there is no other excuse except making yourself aware of this. There is tremendous amount of educational material on TV and media and elsewhere. Simple paying attention to it. If you have the right risk factors, try to be conscious of it. If you have those symptoms, try to use these resources, and that could potentially be life-changing for you and your family. So I'm really thankful again to have Dr. Hammett and Dr. Venkat join us tonight to have a very lively discussion about this heart attack program. And this will be the last program for this year, but we really are very eager to bring this show back next year in some format to our audience. And we thank all of you for tuning in and watching us week after week and calling us with interesting questions and participating in this show and making it a great success. And I want to thank all our audience and my team members here and all the crew guys here who do a fantastic job in bringing this show. And I want to thank all of you guys again to watch us. Good night.